Good morning. I am still Molly Shields, and I will be presenting today on the trends in acute cholecystitis management within an emergency general surgery registry. And this is done in conjunction again with USU and Walter Reed. This is my disclaimer and no disclosures. So a EGS registry or emergency general registry has many different valuable reasons for why it should be used. It's one for tracking emergent non-trauma patients, then developing multidisciplinary protocols from tracking that data, developing standardized treatment algorithms, providing quality assurance based on the data that you can find, identifying those areas of improvement, and optimizing patient outcomes. And in our EGS registry that we developed at Walter Reed, the main facets of subdata that we looked at, we're looking at patients with pancreatitis, small bowel obstruction, GI bleeds, cholecystitis, and small bowel obstructions, all to be able to look at different types of patients and their treatment. And for this study today, we look specifically at cholecystectomies and difficult cholecystectomies, laparoscopic subtotal versus the conversions to open. So we asked the clinical question, is there a difference in patient outcomes between laparoscopic subtotal cholecystectomies and those converted to open procedures? So in the event the surgeon cannot confidently identify a critical view safety, the options then become continuing laparoscopically and completing a subtotal cholecystectomy or converting to open in the hope that the view may be more favorable. And in Figure 1 and Figure 2 here, they're just diagrams of a laparoscopic subtotal cholecystectomy with open or fenestrated stump with the posterior wall in situ or resected. And at our institution, the fenestrated procedure was a surgeon preference, so that was the common procedure here. For the data, this was a multidisciplinary retrospective study that was looked at a tertiary military hospital over a 5-year period. This was at Walter Reed from 2017 to 2022. There's a total of 274 cholecystectomies reviewed. And we were looking at identifying trends in acute cholecystitis management as part of a process initiative improvement. So the results that I'll explain to you are kind of in 2 different facets here. First, we'll break down the different procedures that were done. This would be of the 274 cholecystectomies that were done from 2017 to 2022, 253 or 92% were laparoscopic total cholecystectomies as shown in the blue wedge here. There were then 9 patients, or the 3.2% as shown in the red wedge, who underwent laparoscopic to open total cholecystectomies. And then the 1% is just procedures that did not fit into a specific category, so were denoted as other. And then in the 4%, or the, I guess it's a white silver wedge here, 11 patients underwent subtotal cholecystectomies, as shown in the 4% there. So then that 4% was then subdivided further into the pie wedge on the right that you'll see. So of these 11 patients, 6 were laparoscopic to open fenestrating procedures as shown in the 2.2% in the yellow half of the pie. And then 5 were laparoscopic fenestrating procedures as shown in the 1.8% or the light blue. So as you can see, the majority of operations were started and completed as a laparoscopic cases and accomplished a total cholecystectomy. However, there's a small but not insignificant minority of patients that have gallbladder disease that requires surgeons to make a decision regarding their approach and how to proceed safely and effectively with their operation. Second set of data we'll look at is the trends that emerged from the data from the prior slide. And we found that after analyzing the trends in the data, our registry found that a postoperative ERCP was required in 33% of the laparoscopic to open subtotal procedures and 40% of the laparoscopic procedures for bile leaks. Additionally, the median length of stay was 7.5 days for a laparoscopic to open subtotal cholecystectomy versus 4 days for a subtotal procedure that remained laparoscopic. And there were no common bile duct or hepatic duct injuries regardless of the procedure. So in conclusion, the experience of this registry demonstrates that most patients who undergo subtotal cholecystectomy do not require a postoperative ERCP for bile leak. And additionally, there's a trend towards decreasing length of stay in subtotal cholecystectomies that remain laparoscopic rather than converting to open. And this has changed our practice to trying to optimize patient outcomes by staying laparoscopic if possible to hopefully decrease their stay in the hospital and improve their outcomes. And so these findings demonstrate the general value of the EGS registry in improving outcomes for patients by being able to analyze the trends that emerge from the data. So in summary, similar to the way trauma centers are mandated to collect registry data, trauma surgeons have been able to analyze outcomes and improve evidence-based medicine because of that data. However, this same mandate for emergency general surgery does not quite exist, or it's in the beginning stages at this point. So as a result, there's no comprehensive database to serve as a large-scale analytics resource to collectively advance the management of EGS patients in the same way that trauma patients have been able to use their data to then improve outcomes. So our model is one of the first mature registries, to our knowledge, to assemble institutional patient data, and has shown how analyzing standards of practice and patient outcomes can offer continual process improvement within that institution, and then can be applied more globally to other institutions outside, similar to the trauma setting. And so overall, this EGS reviews can provide quality assurance and identify areas for improvement, as well as optimizing patient outcomes. And that's it. Thank you.